Hi, Dr. Doug Wyland from the Steadman Hawkins Clinic of the Carolinas. Today we're going to talk about the knee joint, in particular arthritis of the knee. Oftentimes when a patient has a diagnosis of arthritis of the knee, they become quite fearful and are unsure of what that all means. Let me try to break this down, discuss some of the non-operative and operative solutions that we have so that you can get back to your regular lifestyle, whether it be walking around the block or playing out in the fields. Arthritis, in its very generic terms, broken down, is arth is joint and itis is inflammation. And yes, you may have arthritis. There's reasons that you might have arthritis. Let's go through some basic anatomy of the knee to understand a little bit what's going on. The knee joint is made up of three compartments. There's the area of the undersurface of the kneecap, and where the kneecap tracks. This is called the patellofemoral compartment. Most of the time, when a person has arthritis, they do have some wear and tear of the cartilage surface underneath the kneecap. The other areas of the knee that are involved with arthritis can be the meniscus tissue, which is the cushion cartilage, depicted here on the right knee. This is the medial meniscus, and then the outer meniscus, called the lateral meniscus. Sometimes the meniscus can break down and tear, and that can cause joint inflammation. The surfaces of the cartilage above and below the meniscus is called articular cartilage once again, and that can wear down. Again, it's a wear and tear phenomenon that occurs with the meniscus tissue, the cushion cartilage, and also the articular cartilage. That's the combination of events that usually occur when a person has arthritis. Sometimes arthritis comes about because of old trauma. Sometimes it's because of a systemic problem such as rheumatoid arthritis or gout or lupus. In any event, when you have wearing down of the cartilage and the meniscus, the joint becomes very stiff. The normal joint lining, which is very pliable, becomes stiff and thickened, and the joint has a hard time moving through a range of motion. The tighter the joint is, the more shear forces are created on the surface of the cartilage. So that causes more wear and tear of the cartilage. And it's kind of a downward spiral for a joint that's tight, that has cartilage wear. Our whole goal in treating your arthritis is to try to gain range of motion, to make the tissues more pliable, and oftentimes that leads to less pain and more function. We have several non-operative management strategies when treating your arthritis. Most of the time we'll start with an exercise program. Oftentimes it'll be a non-impact exercise program such as stationary biking or swimming. Sometimes it will include walking, but exercise is really the mainstay of treatment for an arthritic joint. We know that if a person has bad arthritis, but they have good mobilization of the soft tissues, they'll usually have less pain. In addition to physical therapy, sometimes we use over-the-counter medications such as anti-inflammatories, the generic ibuprofen or naproxen, and some of the newer medications. Oftentimes we'll try injections such as cortisone, which is a one-time injection. It can oftentimes give good pain relief for up to 4 to 8 weeks. Sometimes we'll try lubrication type injections called viscosupplementation. That comes in many different brands, and that's also been shown to be effective. The reason why the viscosupplementation may work is because it seems to stimulate the joint lining to make a higher viscosity joint fluid. At the end of the day, if you have a joint fluid that's a little heavier weight and has higher viscosity, even though your surfaces are worn, it may lead to less symptoms and less pain. All these strategies are designed to try to keep you out of the operating room and give you back a less painful and higher functional joint. Sometimes the non-operative strategies don't work, and we like to combine an arthroscopic procedure, which in combination with those other strategies can make a big difference. Sometimes we'll recommend arthroscopic management if a person has just too much wear and tear to overcome with the non-operative treatment strategies. When a person comes into our office, we'll evaluate the knee to determine the range of motion, the amount of stiffness present in the knee, which will determine by how easily the kneecap moves, called patellar mobilizations. We'll get a sense if the knee is very swollen, if it has a lot of extra fluid, and we'll get a sense of the muscle strength. We'll also obtain radiographs. With the x-rays, we'll obtain weight-bearing views to determine if your alignment is neutral, or if you're particularly bow-legged, as this person might be on the right knee, or if you're particularly knock-kneed. Determining the mechanical alignment of your knee is important because oftentimes we can treat some of these problems with bracing. If a person is particularly bow-legged, such as this would be on the right side, we might use a brace that straightens out the knee a little bit, takes weight off the inside. That's called a medial unloader brace, so that you bear more weight on the outside, and vice versa. So we like to gain keen insight into the aspects that are going on with the knee with x-rays. Sometimes we'll obtain an MRI study. With the MRI, our aim is to determine the condition of the cartilage, the amount of thickness or thinness, or determine if there's any problem with the bone, such as bone cysts or advanced arthritis. We can see the joint lining, we can see how inflamed it is. We can also see the ligamentous structures and the meniscus tissue to determine if there's significant tears or just some minor wear and tear. Once we combine all of our information, we'll make the best plan for you. If you have a major tear of the meniscus or a large area of injury to the cartilage or wear of the cartilage, or if the joint is particularly tight and it's not responding to physical therapy, then we will recommend arthroscopic surgery. The arthroscopic surgery that we recommend in your case is a combination of procedures that we perform through small poke holes. Arthroscopy is performed as an outpatient surgery, typically taking about 45 minutes. We make poke holes in the front of the knee, sometimes 2 or 3. We'll go inside the knee and we'll look at all the surfaces of the joint. Once the articular cartilage is assessed, we'll use a shaver and sometimes smooth down these fibrillated cartilage edges. Part 1 of the strategy is to try to smooth out the joint, just as we've done here. Part 2 of the strategy with arthroscopy would be to remove any tears of the meniscus. If you have any significant tears that are catching or causing locking, then we'll trim those edges, smooth up the meniscus that's remaining, contour the meniscus, and leave the rest of the meniscus alone. We try to preserve as much of the tissue as we can. Part 3 would be addressing any of the inflammatory tissue on the inside of the knee. The inflammatory tissue is depicted as red, looks to be inflamed tissue. It's called synovitis. We'll use a heat probe or in combination with a shaver to remove many of the areas of synovitis. We're careful not to try to cause too much damage to the joint lining because we don't want to stir up and produce more scar tissue formation. So we're quite careful about how we address this joint lining inflammation, usually with the heat probe and the cautery to minimize any bleeding in the joint. We'll perform procedures where we release structures called plicae. Sometimes there'll be scar bands from prior injury or trauma, which we'll release. There's also a specific area of the knee which we like to address. It's called the anterior interval. The anterior interval is an area of the knee depicted here behind the patellar tendon and in front of the tibia bone. Oftentimes, if a person's had trauma or have had prior surgery, they'll develop scar tissue in this area. If scar tissue is present, we'll be able to see this pretty easily with the arthroscopy. And we use a heat probe to cut through it and also to remove it. The scar tissue is a big component to anterior knee pain and also minimizes the mobilization of the kneecap. Once we remove the scar tissue from this area and other areas of the knee, and we've cleaned up all the loose edges of cartilage and meniscus, and we've removed any loose bodies or any spurs that are impinging, that consists of the package of arthroscopic treatments that we perform inside those 45 minutes inside your knee. So it's not just a cleanup that we perform on your knee, but really an overhaul of the joint, the surfaces, the structures, with the whole goal to regain range of motion, pliability to the joint so that it can regain its full range of motion. The arthroscopic portion of the procedure is just one component to the entire package for your knee. After surgery, oftentimes we'll place your knee into a motion machine so that you can more easily regain range of motion. We'll start specific rehabilitation drills, such as what we call patellar mobilization, where we're trying to maintain the pliability of the tissues around the knee. We'll work on strengthening and non-impact exercises such as stationary bike and swimming. Most of the time when a patient has this procedure, they're back doing most of their activities within a matter of 6 to 8 weeks, sometimes sooner. Even if you have arthritis, there's hope with arthroscopic procedures. It's not just a cleanup, but it's addressing the full spectrum of the knee with medications, injections, rehabilitation, and sometimes arthroscopic procedures designed to remove tight tissue and remove unstable flaps. I hope this has been helpful so that you understand a little bit more about the arthritis in your knee.